Hello, and welcome to the Neurocritical Care Society podcast. I'm your host, Dr. Nicholas Morris from the University of Maryland Shock Trauma Hospital. And today, as part of our Hot Topic series, I'm really excited to welcome Dr. Fabio Taccone to talk about his recently published study, the TRAIN randomized clinical trial. This was a trial of restrictive versus liberal transfusion strategies in patients with acute brain injury. It was published online in JAMA in October. And this has become a really hot topic with a slew of recent publications coming out on transfusion and acute brain injury. So very timely. And I'm really, really thrilled to talk to Dr. Taccone. For those who don't know him as part of our listeners, and I'd be surprised if you don't, because if you don't know him, you know his work. He's an incredibly prolific clinical researcher with special interest in neuroprotection in the areas of cardiac arrest and traumatic brain injury. He's a professor and head of the Department of Intensive Care at Erasmus Hospital in Brussels, and he's joining us from across the ocean. So thanks so much, Dr. Taccone, for coming onto the podcast.
Thanks a lot. It's a very nice introduction. I'm very glad to be here with you and discuss about TRAIN and transfusions in acute brain injury patients.
Wonderful. Well, let's start with a little bit of sort of the background to all of this. So sort of over the years, a restrictive transfusion strategy has become more or less standard of care for most of critical care, really probably around the TRIC trial. But there's some reason to believe that maybe patients with acute brain injury are different. So what are some of the differences between the general critical care population and the acute brain injury population that warrant further study in transfusion targets?
I think this is, of course, a very relevant question because when I started to work in the ICU, of course, the TRIC trial was released in 2 years, and we were all being influenced by the results of this trial, basically moving towards restrictive strategies. Of course, it's not the only trial. We also have a trial in sepsis, for example, that also showed similar results. When I started to work on the topic, there were 2 points that struck my attention. The first was that there were basically no brain injury patients included in those trials. And also the fact that we consider anemia in general as a potential secondary brain injury occurring in these patients. But basically, we don't know at which level of hemoglobin, which is what we use in the clinical practice to trigger transfusion, we should start to consider those transfusions. And again, from the physiological point of view, it's very nice to remind to everyone that an healthy brain, if you induce isovolembic anemia in healthy people at 5 grams deciliter of hemoglobin, healthy brain starts to make errors in very easy tasks. A very nice German paper in anesthesiology a few years ago, which shows again that if you dilute too much the blood and you reduce the oxygen content, even an healthy brain start to suffer from very mild signs of tissue hypoperfusion. In patients with brain injury, I presume that this, adaptive mechanism of vasodilation, increased regional blood flow are of course impaired because of the brain injury. So at hemoglobin around 7 to 9, which is basically what we use in clinical practice, there might be patients with tissue hypoxia at levels of hemoglobin that we consider to be safe. This is basically the background when the TRAIN study and of course the other trial that been recently published has been developed by investigators.
Great. Well, that's a wonderful review. Now, there were a couple of trials that really targeted patients with acute brain injury prior to the TRAIN trial, and I think we'll get to HMOTION later. But one of those that is sort of maybe a landmark trial in the field is Claudia Robertson's study. Can you describe a little bit how the TRAIN was different from that study, which was published over 10 years ago now?
Yeah, so this is, of course, a very relevant paper published by Claudia Robertson group in Texas. It's a single center study on TBI. And the idea of the trial, it's very important for people to understand, is that they tried to study in that trial 2 different interventions. It's a factorial design. First, of course, use 2 different transfusion strategies, 7 grams deciliter versus 10 grams deciliters of hemoglobin to start transfusions, and erythropoietin versus no erythropoietin. So of course, as you want to give erythropoietin as soon as possible, patients were randomized at hospital arrival before they became anemic. That's why when you look at the hemoglobin values reported in the trials, in the restrictive group, the median values are around 10 grams, and in the liberal group, it's 11.5. So basically, to me, they compare the liberal versus a very liberal strategies. And then if you see the results, you even see a signal against the liberal strategy, more infection, more FDS, more thromboembolic events, because of course, transfusions are considered like a drug, like an intervention. So if you give it too much, increase hematocrit, of course, we all know the red blood cells are not exactly working as the one that we have in our body, you can increase complication. So that's a very important. It's very nice to read, behind the abstract, looking at the value, because these are not anemic patients. All the recent trials tried to investigate these transfusion strategies in patients considered to be anemic.
Great. I think that's a really important point and critical to understanding these trials and maybe their different findings. Maybe now would be a good time we can talk a little bit about the TRAIN protocol. So you mentioned you enrolled anemic patients. And so what was your threshold for anemia and how did you choose your hemoglobin targets?
This is, of course, a very important question. When we considered to develop the study, we started from a very simple survey conducted within the European Society of Intensive Care, published in Critical Care. Rafael Badenes from Valencia is the first author. And basically, we questioned many people. I remember NCS also supported at that moment this survey. So we had around 900 respondents, mostly from Europe, but also a lot from North America. And basically, we saw that 75% of respondents would use a trigger between 7 to 9 grams of deciliter of hemoglobin to consider transfusion. We also, of course, consider the fact that in most severe patients, people could have used maybe a higher trigger, but in general, 7 to 9 seem to be the range, of hemoglobin values where you could consider to develop a trial. I have to say something. When we sat down and we developed the protocol, the first question we asked ourselves was, do you think that if we consider 7 versus 9, we'll be able to properly separate groups? Because it's important, of course, that two groups are different, because if they're very close in terms of hemoglobin, you basically will not find any difference in the potential of tissue hypoxia. And we, of course, had the publication of the study on sepsis, which showed that it was possible to separate groups. In the meanwhile, when the protocol was ready, a Brazilian study was ongoing, and they told us, preliminary data, they were able to separate groups. So basically, we stuck to our data and we said, consider 9. Many observational trials have found 9 grams deciliter as the value of hemoglobin associated with more tissue hypoxia, with more metabolic crisis, with a higher risk of poor outcome. So also considering observational studies, we found that 9 was reasonable and 7 was very easy because 7 was the restricted group considering all other trials. That's how the two transfusion strategies were developed for the TRAIN protocol.
Great. And so what was the trigger for enrollment in the trial and how long did you maintain the transfusion target?
Yeah, so we basically started from nothing. Consider then more than 10 years ago, except the trial from Claudia Robertson, we had nothing. So we said, how we should select patients. So we said, okay, of course, we said people should have a minimum of brain injury. So we said, let's take the GCS. Everyone takes a GCS in the ICU, is not asking to be a neurologist. Let's say 13 or less than 13. Okay, then hemoglobin less than 9. We didn't want to study patients with the anemia developing after 4 weeks of ICU stay, because we felt that, if anemia equals higher risk of tissue hypoxia, this tissue hypoxia, we know now it happens in a quite early phase. So we said 10 days from the injury and expected ICU stay of 72 hours. These were the criteria we chose, 72 hours, because of course we don't want to randomize the patients that will be discharged the day after. The discussion was around the kind of brain injury to include.
Mm-hmm.
We considered the beginning to study only TBI, but we also said, we know that patients with SAH are very prevalent in the ICU. They also develop, of course, earlier and even in the late phase, some tissue hypoxia. It's quite logical to include them. And at the end, we also came out with the ICH. We have to consider that when you compare Europe with the US, for example, basically we don't have ischemic stroke in the ICU. They go to the stroke unit, but we still have a lot of ICH, in particular those with larger intracerebral hematoma. And there was some studies suggesting an association of anemia with poor outcome. So at the end, we said, why not including these three kinds of injury? They're quite heterogeneous, but if there is a signal in favor of lower hemoglobin, more complication of tissue hypoxia, probably this will come out regardless of the baseline kind of brain injury. That's how the protocol was developed.
Great. I was going to ask about the exclusion of ischemic stroke patients. That's sort of a very pragmatic reasoning that they just don't tend to
Absolutely.
be many of
Yeah.
them in the ICUs in Europe. Great. Okay. So anytime someone developed anemia within 10 days, they were randomized to either a target of 7 or 9. And you all, as you intended, you were able to show a nice separation between the groups. What were the outcomes that you were looking at, and how did you come to choose those outcomes?
So we consider that, in the field of brain injury, it's not only important to survive, but you should survive with some neurological recovery. At the moment the protocol was developed, we basically use a very classical frequentistic approach. We said there are two groups. We have to calculate the expected proportion of poor outcome in the control group. And again, based on, I would say, almost nothing, we said 15% mortality, because many studies in TBI in Europe reported in selected patients 15-20% mortality, and 35% of risk of poor outcome, because we selected, those who were anemic, so they stayed enough in the ICU, a GCS less than 13. And we said, well, we will be able to probably reduce the occurrence of poor outcome from 50% to 45%. This was the idea of the protocol. We selected the GOSE as the scale to assess neurological outcome at 6 months. Why at 6 months? Because we said, many studies in TBI, even hypothermia before us, already used this endpoint. So we thought that 6 months was enough to leave to the patients, at least for the knowledge of the moment, enough time to recover. And we use GOSE because, it has 8 different possible values from 1 to 8. For those who don't know, of course, 1, you are deaf, and 8 is the best neurological recovery. And when you use this kind of, more detailed scale, you might maybe try to better describe the changes, the shift between the different scale. It would be more accurate than the GOS. It's only 5, for example. Of course, we discussed a lot because we know that we are including patients with cerebrovascular diseases, and that the best would be a modified RMD scale. But at the end, we said, well, GOSE looks to be appropriate in TBI. There is 8 potential values which will give more discrimination between the different outcomes we will obtain. Let's apply this to all the kind of range we will include. And as I told you, so that's how we selected the outcome.
Yeah, I always think this is such a fascinating part of trial design, and it's so challenging. And really, in many studies, really ride on the selection of the outcome, at least the way we interpret them does. Any secondary outcomes that the listeners should kind of be aware of that you feel are particularly important to point out?
So we collected the mortality at 28 days as a secondary outcome. Of course, that's also mortality at 6 months. We collected ICU hospital length of stay. We also included the composite outcome, which was a combination of mortality or at least one organ failure over the ICU stay. We felt again that, imagine that there is no effect on the brain, but there might be an effect on tissue hyperperfusion. Maybe you could detect this difference when you look at the SOFA score, and which quantifies a little bit organ failure in the ICU. And these were, predefined. And of course, we included, as in all trials, I would say a bunch of serious adverse events. I don't remember if they're 13 or 14. I would say if you see the list, they're quite reasonable. Some of those are associated with transfusions, like, TRALI or TACO, so with hemodynamic complications. We included, of course, infection, sepsis. We included, of course, anaphylaxis, errors in transfusion. I mean, everything you see there looks quite reasonable. At the moment the protocol was created, you will see that one of SAA was also tissue hypoxia, defined by the measurement of the brain oxygen pressure using basically, the PbTO2 monitoring catheter. Of course, this was very enthusiastic because, conceptually you want to show that if you are changing transfusion strategies, the oxygen delivery to the brain will be changed. So you'll be maybe higher oxygen values in the liberal group But of course, this was not mandatory. So it is reported, but the number of patients with the PT2 catheter was very low. So it's an SAE that was not really relevant for the trial.
Great. Maybe a secondary paper at some point that we
Yeah,
look
but there are
forward to that.
so few patients. I think there
So
are
few,
10 or
huh?
15. So that
Oh,
one
okay.
will not help us, unfortunately, no.
Got it. Got it. And how much standardization across sites was there in terms of the general management of these patients? Were there strict protocols, or were sites pretty much allowed to treat these patients as they normally would, and this is the only
Yeah.
difference?
This is, of course, a great question, because you can imagine this trial started as an European trial, but became basically a trial involving other countries. And we have centers in Asia, we have centers basically in South America. And what we said in the protocol, that we recommended to the participating centers to follow the guidelines, at least for the management of these patients. But we also wanted to be pragmatic, because as you know better than myself, most of the intervention we make in the ICU should not be only effective in the setting of strict following of the guidelines, because sometimes guidelines do not give you all the right information how to better manage the patients. So we said you should follow the guidelines available to basically manage, but we are collecting data within the ICU stay that give us an idea on how these patients are managed. But we won't, of course, change local practices, because there would be some centers, for example, I make an example of South America, the availability for ICP monitor will not be the same than Europe. So we
Sure.
cannot force them to change what they have done over the last decades. So, so we accepted some heterogeneity within centers, provided they were applying their local protocols, if there were any local ones, to all the patients randomized to the trial.
Great. Was there any blinding during the study?
So we, as healthcare providers, were not blinded. This might be considered as a bias, of course, so we can discuss more when you look at the results of the trials. But from the practical point of view, it would have been very complicated to ask someone else to decide, cover the bags, or give something like fake blood or whatever. I don't think this is, I don't remember any other trials in transfusions where healthcare providers were blinded. Of course, outcome assessors were blinded for the arm assignment. And this is important because in terms of interpretation of the results, the fact that the healthcare providers are not blinded might be considered as a bias on the reported results.
Yeah, well, one thing that we always consider in trials of patients with acute brain injury is withdrawal of life-sustaining therapies and how we might correct for those or not. So was there any guidance to the sites in kind of how to do neuroprognostication or any blinding of neuroprognosticators? This is something that's been part of the TTM studies, for instance.
Absolutely. This is, of course, a very relevant question. We have now, of course, everyone knows the guidelines published in neurocritical care about prognostication in TBI. We have prognostication under formal brain diseases, even spinal cord injury now. But at the moment the trial was initiated, the way that you could provide an adequate prognostication algorithm accepted everywhere was basically impossible. So I would say that withdrawal life-sustaining therapy is reported. We have not worked yet, but there will be some secondary paper on reasons of death in the study. So we have reported whether it's brain death or medical complication or withdrawal life-sustaining therapy, so we can easily report this data. I'm quite confident, again, it's an interpretation of the results. I'm quite confident that the intensity of care that patients have received in two arms of the study were similar. How we can say that? Mortality was the same. I would assume that the large majority of patients where you withdraw life-sustaining therapies because they have extended brain injury, they will probably end up with death. So mortality was the same. The ICU and hospital length of stay was the same. Again, we did not discharge too early or too late, one on the other, to protect those in liberal transfusions, keeping them in the ICU, and discharge the others to the ward at the floor where they would be less monitored. In terms of vasopressors, fluid balance, this was quite similar. So again, these are all indirect measurements that probably the intensity of care was the same in two groups.
No, I think that's compelling evidence. Maybe as we move along now, maybe you can summarize the major findings of the study, because these are really, I think for many people, perhaps not surprising, but maybe even practice changing. So what did you find?
So I will start from your sentence, surprising, because of course you get the results from the statistician, you see the results, say, okay, and then you organize a meeting with your colleagues. So it was the investigator meeting where they presented for the first time the results of the trials. And some of the colleagues said, we thought that this kind of study deserved to be done. And of course, the train study and the motion SARA, the other trials, show clearly that this was a relevant question for the patients with acute brain injury, but we did not expect so huge difference in the outcome measurement that was reported. So for those who are not reminded or not aware of the results of the trial or the train study, we reported an absolute 10% reduction of the occurrence of the unfavorable neurological outcome in favor of the liberal group, so dose transfused and 9 grams per deciliter, which corresponded, if I'm not wrong, but there will be a small error, around 13.8% relative reduction of the occurrence of poor outcome in favor of the liberal group. When you see the results of the trials, you have a relative risk of 0.83, of course, 95% confidence interval below 1, and the p-0.002. So I mean, the results are quite clear in favor of the liberal group.
Great. Well, yeah, I think I have to admit, I was one of those people who was saying definitely worth studying, but I would be doubtful that they find a difference. And there was a large difference, as you mentioned. And then I think we can't talk about this large difference without putting it in the context of these two other trials that came out sort of around the same time we've mentioned so far. Hemotion, which looked at patients with traumatic brain injury, and they used a similar enrollment plan where they only enrolled anemic patients, but slightly different targets. And Sahara, which focused on patients with subarachnoid hemorrhage and is the most recently published. And those two trials, in contrast years, did not show any statistically significant difference with their liberal versus restrictive transfusion goals. So what gives? What's the difference between the Canadian group and the European group?
So I will start from emotion. So emotion only investigated traumatic brain injury. They have 752 patients or something like that. I mean, it's a huge cohort. And they included patients considered to be anemic at 10 grams per deciliter, again, based on survey conducted in Canada for TBI. So it's totally reasonable. But the restricted group was also a 7. So our restricted group was similar. The difference is for the liberal group. Now, what is more sophisticated in the analysis of emotion, and of course I have to commend our colleagues, which are much better than myself in statistics. Alexis is a really great guy. When I discuss with him and always learn a lot. They reported the results of the trials with this consideration of the possibility of the baseline of the patient to have a poor outcome. So they just not reported the percentage of one group versus the other, but they corrected for the baseline probability of the patients to have a poor outcome. So the results, as you said, of emotion in terms of statistics are, I would say, neutral study, non-significant. Now, when you look at the primary outcome reported, as I told you, with this correction, there is a 5.8 reduction of the occurrence of unfavorable outcome in favor of the liberal group. If you consider just the dichotomous, so as we reported, frequentistic, minus 6.1 difference in favor of the liberal group. Now, again, to our mind comes the question, is 6% difference in the occurrence of poor outcome something that is relevant for our patients? I would say yes. Of course, we are working now together with the Canadian group in having an individual patients' data meta-analysis, including the patients from motion, the patients from train, only TBI, and 44 patients randomized in this Brazilian randomized feasibility trial published in 2019 in critical care. Gobato is the first name, where the authors basically just wanted to show that it was possible to separate groups. Nice, but they also reported for the first time, and again, we said, well, that's because of the bias, significant difference in terms of unfavorable, in favor again of the liberal group. So we are working also to understand whether combining the two trials, the signal becomes really in favor of being liberal. And of course, EPDMA also would help us to look whether there are subgroup of patients that might more benefit than the others, or maybe with a more sophisticated approach. Now we lack a lot of these heterogeneity treatment effect analysis, characteristic of patients that identify patients with a high probability to benefit, intermediate probability to benefit, or no chance to benefit from a liberal transfusion strategy. So I think that the results go in the same direction, probably with a less, I would say, magnitude, and the combination of the three trials will probably help us to better understand how to move on. I would say, if I want to be a little bit more provocative, that for TBI, probably 9 grams is the new 7 to initiate transfusions in this setting. That's again for trauma. Now, if you move to SARA, that's another story, because SARA
Let's do that.
yeah, SARA randomized SAH patients, again, the same number of patients, a huge trial. So when you compare to TRAIN, we only have 200 patients with SAH. By the way, the SAH paper is just accepted, came out very soon, but SARA will be basically the larger trial in SAH patients in this field, probably for years. It's not, if not forever, we'll see. And when you see the results of the trials, the magnitude of the effect is lower. So just to remind to everyone, the patients were included at 10 grams per deciliter. So it's the same liberal group than emotion, but the restricted group is considered at 8 grams per deciliter. The first important point, you have to look at the values of hemoglobin over time in the 3 trials. They are not reported in the same way because the 2 Canadian trials in New England reported the mean and the 95% confidence interval of the mean. We reported basically 97.5% of the all available values. That's why you seem that there is more overlap in our trial, but basically they're the same. And when you see the SARA trial, most of the values in the restricted group are above 9. I would say it looks like more our liberal group than a restricted group. And of course, the liberal group is more around 10.5 to 11 than 10. So again, it is possible that this selection, this criteria, when the patients are transfused at 8, will expose these patients to a lower risk of having these very low values. Maybe 7 is bad, rather than maybe 9 is good. 7 is really bad. So it's possible that this selected trigger would expose these patients to a lower risk of tissue hypoxia. The second important point I would like to mention is that in the TRAIN trial, the median GCS on admission was 7, or randomization was 6. So these patients were sick. We have 91% of patients on mechanical ventilation. In the SARA trial, the median GCS, I try to understand because you see the distribution of WFNS, there's no GCS, but basically 50% of patients are good grade, which means they are GCS 13 to 15. So these patients are probably less sick. They're only less than half of them on mechanical ventilation. And the overall occurrence of poor outcome is 30%. In our trial, 70%. So it is possible that because of the selection of the hemoglobin value to go in, and because of the values they've been using over the trial, they are not entirely so sick, I would say. It's not, again, a criticism, it's my interpretation, my personal one, as the SAH we included in TRAIN. And the exposure of tissue hypoxia was lower because of the selection of the one. Now, a last point I would like to make to everyone. The selection of the poor outcome in SARA was modified Ramsey scale of 4 to 6. Now, I'm not a neurologist, I'm not a vascular neurologist, but I've learned that in stroke, you basically use MRS of 3 to 6 to define poor outcome in most of the trial on stroke. If you consider MRS of 3 to 6 in the SARA trial, there is again a 6% absolute reduction of poor outcome in favor of the liberal group. Again, 6% irrelevant. So these are all points that I've tried to came out, not because I want to criticize any study, but I try to understand how the results of the TRAIN study could be considered together with, of course, the 2 big other trials published in the literature. So these are just points that I like to share with you and the audience so that everyone can make his own opinion, look at the trials again, and try to understand whether these points could explain part of the difference of the reported results.
No, I thank you very much for that analysis. And I agree with you. We just had a journal club with our faculty and fellows looking at the Sahara paper in comparison to TRAIN. And we made the same comment. And this is what I was talking about with the outcome selection, right? It's so important in how we interpret these trials. And actually, if you go from the stroke literature, if you look at the Grotto bars of the modified Rankin from the Sahara study, I don't know that they reported that analysis, but it looks like maybe an ordinal analysis would have been positive. So really, really interesting. And the point about severity, I think, is a key one, how sick these patients are. Great.
So just to add a very short point, of course, we have been in touch all together, by email and even by video call. We also plan to do an EPDMA of SH patients, knowing, of course, that Sarah will have the larger weight because they have 800 patients. We have only 200 in TRAIN. But I think combining again these patients might identify maybe some subgroup of patients who could more benefit from a liver transfusion. So we have even more research coming out in the next months, I hope, combining these 3 large trials recently published.
Wonderful. And to finish up, I think we sort of skipped over the adverse events, but did you see any increase in adverse events with liberal transfusion group or with the restricted?
So we didn't, except for one, a lower occurrence, a significantly lower occurrence of a cerebral ischemia in the liberal group when compared to the restricted group. If I remember well, is 8.5 versus 13.305 in the restricted. So of course, this is, I hope, well reported in the discussion. It was requested by the viewers very adequately. This was the cerebral ischemia, new cerebral ischemia after randomization, as reported by the investigators. So there was no protocol stating that after 3 days, 5 days, 7 days, CT scan was mandatory. And of course, this ischemia could be detected on CT or on MRI. Why? Because we didn't want, again, to change the practices. We should have the money to pay for additional imaging. Just to remind everyone, this TRAIN study has been conducted with only 170,000 euros. So
That's amazing.
That's for me the bigger success. Very enthusiastic people that I have to thank for their participation. So we could not ask. So of course, this is a major bias because of course, the reports of the investigator was done in CRF. We didn't ask to double check the imaging. So of course, these data should definitely be maybe a target in a future trial on transfusion. We should consider mandatory brain imaging to see whether this is reproducible or not.
Absolutely. I think that's a key point. And you mentioned, or I can't remember if we mentioned, but in Claudia Robertson's paper, there was an increase in venous thromboembolism in the group that had the liberal transfusion. Was that similarly, there was no protocol for assessing that in this trial? Yeah.
So this was also requested by one of the reviewers saying, you have reported no difference in the thromboembolic events, but this was reported in the previous trials. And we also acknowledge that, of course, this was reported according to the investigators, probably only those who were really relevant or pulmonary embolism, but there was no systematic routine search for any VT.
Well, great. I think we hit many of the main points. I'm wondering, it sounds like this has changed your practice in traumatic brain injury. Is that correct?
Yes. In our department, we have changed from 7 grams deciliter. We've been very restrictive, really. We had some publication in the past where really the median value of hemoglobin before transfusion was 6.5. So we really changed our practice. So we discussed internally with those guys working in the hematology department, coordinating all the transfusions and blood availability in Belgium. And we said, this is reasonable study to change practices. So this is what we have done. Maybe it would be interesting, maybe in one of the survey, just to see, after publication of 3 trials, if we do a survey now, which will be the responses that we will get. Some centers could still remain restrictive. I think that we have, honestly, good evidence for TBI today. Probably the results from SARA, the way that are presented, are even more neutral than the motion. But again, maybe combining the results, we will try to came out with some analysis that might help clinicians to set up maybe or not a new hemoglobin trigger to consider transfusion.
Great. Moving forward, besides the combination of data with the Canadian group and from Promotion and Sahara, What else do you have on the horizon looking at transfusion thresholds and acute brain injury? What questions do we still have to answer?
Well, there is a question that I always have in my mind because this was my practice before, whether, from the purely intellectual point of view, I would say if we can measure tissue hypoxia, I would give, of course, intervention aiming to increase oxygen delivery. So if I would have the money, I would have tried to make a study where, of course, in those patients selected to having a multimodal neuromonitoring, so they would be only in severe TBI, for example, I would trigger the transfusions based on the use of a PbO2 monitor. I think that the way that the protocols are now available in the literature, we are participating to Bonanza, which is basically as boost tree. The role of transfusion is really at the very end. So we start from increasing CPP, increasing oxygen, maybe changing PCO2, sedate more, but the transfusion is really at the very end of the intervention. Maybe it is possible that some patients might require higher levels of hemoglobin in the very early phase. We don't have today a bedside variable that tell us if the PbO2 is below the threshold, that is not due to a problem of flow, it's a problem due to oxygen content. We don't have today. I mean, we have maybe some surrogate, we don't have it. So that would be in this moment. Now we're running, of course, Bonanza, but these are some data we are collecting even more to understand how to potentially predict the response of transfusion at the level of tissue hypoxia when we have a patient, let's say, below 9 grams per deciliter. We're not planning to do another randomized trial. I mean, just to remember everyone, in 2012, the Canadian published the systematic review telling everyone we don't have trials. So we basically created together our protocols, 2013, 14, and it took 10 years to make this study available. So, it's a huge investment in terms of, of not only money, but also of time. So I'm not sure that at least myself, I don't know, Alexis and his colleagues, will have the force to run again a new trial in this field. So we are maybe try to understand whether there are other factors that help us to maybe more fine-tuning the selection of hemoglobin as one of the markers to choose for transfusion in our brain injury patients.
Excellent. Well, I think I would be remiss in talking about transfusion without just pointing out some of the early work in this was done by the group at WashU with Raj Dar and Mike Dieringer using PET-CT and showing improved oxygen delivery with transfusion. And I think what you're suggesting is kind of building on that work at a larger scale to look at physiology, which we would all really
Absolutely.
welcome.
Absolutely.
I want to congratulate you on, finishing a study like this and on that budget. That's incredible. I mean, that is really, really, I wasn't aware that the funding was that low, and to take a trial over the finish line with that level of funding across all of these centers across the globe is an incredible achievement.
Thanks a lot. And I hope to be in the next NCS Congress in Montreal. So if any colleague would like to have any discussion, I would be very pleased. And thanks again for the invitation and a very nice discussion we had.
Wonderful. Well, we'll end at that. So thank you so much to Dr. Fabio Taccone and the trained trial investigators. We've learned a lot from this study, and to many of us, it will be practice changing. That's it for the Neurocritical Care Society podcast. Tune in next time. Please like and subscribe on your wherever you get your local podcasts, and we'll see you back soon. Take care.
Bye-bye.